Senior Director and Head of Clinical Cardiology and Advanced Cardiac Imaging at Fortis Memorial Research Institute, Gurgaon. So today we will talk about a new molecule, inclisiran, which is a lipid-lowering drug, injectable and new in the market. But it just with all new drugs, it will have its own dilemmas and doubts as to where it should be used in the present continuum of anti-lipidemic drugs. So we will touch upon some very basic concepts about this new molecule called inclisiran. So to begin with, we have to understand that after about nearly 50-60 years of research in lipids, even at present, our main goal or focus is the LDL, the LDL-C levels. If you look at, say, 15 years back, we used to give a lot of weightage to HDL, but now that theory is out of the window. HDL is more of a marker, not a therapeutic target at the present moment. The triglycerides, again, are important in terms of they being detrimental to your health, but there is no strong evidence that triglycerides being high will lead directly to heart disease. The kind of data we have with LDL-C doesn't exist with any other component of the lipid profile. So it is important to know the optimal and safe targets for LDL-C in patients who are at high risk or who are high risk ASCVD, which is atherosclerotic cardiovascular disease patients. And this question is again very important and very old as to how low can we go. Well, if I decrease LDL-C to say 10 or 5, will it affect my cognition? Will it affect my bodily functions? Will it affect me adversely? Will it cause depression, etc.? So when we start analyzing the data, why is it important that we talk about LDL, especially in the Indian scenario? Because we are getting heart attacks and heart disease much earlier than our Western counterparts. Every fifth heart attack occurs in less than 40 years of age, and every second heart attack occurs in less than 55 years of age. So we have to be cognizant of the fact that we are at high risk as a country, as South Asians, and the strongest evidence we have of today is with LDL-C levels being high, strongly related to the risk of, in a strong and linear fashion, the risk of atherosclerotic cardiovascular disease. And we are not talking without evidence. Just look at this slide, and you can see that there are multiple, trials starting from, Jupiter, Ascot, TNT, HPS, HOPE-3, Ideal, Lipid, TNT. So a lot of these trials have shown that there is a linear relationship between high LDL levels and risk of atherosclerotic cardiovascular disease in a linear fashion. So each millimole, which means about 40 milligram per deciliter of LDL rise, is associated with nearly 20% increase in major cardiovascular events. And if you decrease LDL by that margin, you decrease about 1/5 reduction in major cardiovascular events by reducing LDL by about 40 milligram per deciliter. So what has changed in the guidelines is simply the fact that we want to strike early, strike strong, and there is a shift towards intensive LDL-C lowering as early as possible in high-risk patients. So if you look at the 2023 ESC guidelines or CSI guidelines, we want the LDL-C reduction in high-risk patients to be below 55. These are more of European guidelines. The American guidelines had kept it at less than 70 initially, but now everybody is quite okay with 55 or below as the target in high-risk patients. In patients who have, who have had a second event, like suppose somebody had an MI or CABG or stenting 2 years back, and within the next 2 years they get another cardiovascular event, then they come into very high risk category, and the LDL-C goal shifts to less than 40 milligram per deciliter. What we basically want is the LDLC. Suppose my LDLC is 200. My LDL level is 200, and I want to bring it down in a very, if I'm a very high risk patient, then I would want the reduction of LDL to by about 50%, which means I want it below 100. So how do I achieve it? If I give statins, will they be able to bring it down by 50%? No. So I add ezetimibe, I add bempedoic acid. Will they be able to bring it down collectively to that level? Maybe. But then I can still not bring it down to less than 55. So that's where you start looking at other components or other drugs which can bring down LDLC levels to less than 55, which is your target in high risk patients. And how do you achieve that will depend on patient to patient and what is your initial LDLC goal, LDLC values. So my target, if I look at the Indian Lipid Association of India consensus, in very high risk patients, we want LDLC reduction to below 50 milligram per deciliter. In very extreme CV risk patients, which is, you know, patients who are getting recurrent strokes, recurrent MIs, etc., despite being on high dose statins and other therapy, we would like the LDLC to be reduced further to about 30 milligram per deciliter. So there is another category B and category C where they can go as low as 10 milligram per deciliter also in patients who are getting recurrent events despite being on optimized medical therapy. And this is because of a landmark trial called Fourier trial, which was actually done in patients, about 26,000 patients, where by giving evolocumab, you were able to bring down the LDLC levels to below 10 milligram per deciliter without any neurocognitive or non-cardiovascular serious side effects. So this was the trial which actually paved the way for, in a way, define how low can you go. So you can actually go as low as 10 or below, and yet it would be safe in your patients. So I think that question is now answered, that you don't have to worry about how low the LDL can go. It can be as low as 10, it can be lower. So people who are on, say, PCSK9 inhibitors or inclisiran, in your clinical practice, you would see their LDLs plummeting to about 5, 6, 3 milligram per deciliter, and they're doing fine. First, let us see what inclisiran is. So it's a first-in-class siRNA therapy, silencing RNA therapy to lower LDLC, and it specifically works in the liver. So SI stands for small interfering double-stranded RNA, which is what is inclisiran. And so it mimics the body's process of RNA interference, and which is restricted to the cytoplasm. There is a specific molecule called GalNAc, which combines with this inclisiran molecule and is taken up by the hepatocytes. So we know that because of GalNAc, this inclisiran will go only or enter only hepatocytes. So the next step is that this basically mimics the mRNA, which leads to PCSK9 production, and by inserting itself into the mRNA, it destroys the mRNA and doesn't let the transcription of the mRNA for PCSK9 inhibitors, for PCSK9 proteins to form, and hence PCSK9, which basically uptakes the which is basically responsible for the LDL, the metabolism is destroyed, and hence the inclisiran also works in a very similar fashion as the PCSK9 inhibitors. So when you inhibit the PCSK9, the LDL receptors are not destroyed, and they're able to take up LDL from the blood very efficiently, and hence the LDL levels come down significantly. So the present Indian approval of CDSO SCO approved indication is that it is mainly indicated in adults with primary hypercholesterolemia, the heterozygous familial hypercholesterolemias, and say FH patients or mixed dyslipidemia patients as an adjunct to diet. So your first therapy will still be statins. If if the patient is statin intolerant, then you usually tend to add ezetimibe or bempedoic acid. If your LDL-C goal is not met, then you have the option of adding inclisiran in these patients. Now, inclisiran is important. Some people also ask the question that why not PCSK9 inhibitors? Now, PCSK9 inhibitors are also excellent molecules. They also help in reducing LDL levels significantly. And the only problem is that they have to be given every 2 weeks. They're much more expensive. And it is difficult for any patient to keep taking them for many, many years. So they're impractical in a way, but they're good molecules to be probably instilled in patients who've just had an MI, recurrent MIs or strokes, etc. But for chronic therapy, inclisiran will always score over PCSK9 inhibitors just because it is cheaper and also because it is to be given every 6 months. So it is an excellent addition to the lipid lowering repertoire armamentarium. And if you look at especially the patients who are statin intolerant, where you want them in high risk patients with high risk of ASCVD in future, like diabetics, hypertensive, smokers, multiple risk factor comorbidities, CKD, patients with previous history of CABG, strokes, stenting, or having recurrent events, cardiovascular events, despite being on good medical therapy. They are your targets for adding inclisiran to achieve the LDL-C goal. The suitable patient will be somebody who's at high risk, individuals with atherosclerotic cardiovascular disease, whose goal is not met. And they're especially useful in patients with heterozygous familial hypercholesterolemias because their LDLs tend to be, above 200, and you're not able to bring them down to the required, levels of LDL with the oral medications. The recommended dosage of inclisiran is 284 milligram administered as a single subcutaneous injection. So the way the dosing is, the first dose is at 0 day, then the second dose is at 3 months. After that, it is all doses are at 6 months. So just the first 2 doses are at 0 and 3 months, and then all other subsequent doses are at 6 months. And the injection comes as a 1.5 ml solution with 300 milligram of inclisiran sodium, which is equivalent to the 284 milligram of inclisiran as such. So you can write either 300 or 284 milligram, it doesn't matter. It's a fixed drug syringe, pre-filled syringe, which comes for administration. And this is based on the trials of the Orion development program. So Orion trials actually tested this kind of a protocol, and hence we follow the same protocol. We give it as a subcutaneous injection in the abdomen by a trained sister or a medical professional. And if you suppose miss the dose of the dose which is to be given, suppose the next dose is due, you get one say dose right now in January or February, and then your next dose is after 3 months. So you miss it in April, and you still, if the planned dose is missed by less than 3 months, you can still go ahead and put the inclisiran in a normal fashion. But if the planned dose is missed by more than 3 months, then you have to restart the entire process. So new dosing schedule has to be started at 0, 3, and then subsequently 9 months, and then 6 monthly, like that. So you can also use it immediately after the last dose of PCSK9 inhibitors, which is basically a monoclonal antibody. And so you can, to maintain the LDL-C lowering, suppose somebody is on PCSK9 inhibitors and you want to transition to inclisiran, you can maintain the LDL-C lowering by giving inclisiran within the 2 weeks after the last dose of monoclonal antibody PCSK9 inhibitors, because the PCSK9 inhibitor will work for about 2 weeks, and then immediately within the 2 weeks you can start inclisiran. We have talked about, if you look at the CSI Indian guidelines, Cardiology Society of India, you start with, in a patient of acute coronary syndrome, you look at the non-fasting lipid profile. If the patient is elderly, more than 75 CKD, stage 3 to 5, on lipid lowering drug therapy, then you have to give them 40 milligram of atorvastatin with ezetimibe, or 20 milligram of rosuvastatin with ezetimibe. Otherwise, in all other patients who are not elderly, more than 75, non-CKD or early CKD patient, you start with very high dosages of statins. So it can be 40 milligram of rosuvastatin or 80 milligram of atorvastatin combined with ezetimibe. You start with that according to the CSI guidelines. So they are not, in a patient of ACS, they start with ezetimibe head on to achieve, and the reason is they want to achieve a target of less than 55 LDL-C in these patients. You check the lipid profile at 4 weeks. If the goal is not met, then you can go on to the, if it is less than 55 and the non-HDL-C is is less than 85, then you can just follow the same dosages. However, if the goal is not met, then you add bempedoic acid to this combination of statin and ezetimibe. If the goal is still not met, then that's where you start using PCSK9 inhibitors or inclisiran. So this is what they have recommended, and this is what I've just explained to you in the setting of acute coronary syndrome. Now, if you look at the NICE guidelines, recommend inclisiran both for ASCVD and heterozygous familial hypercholesterolemia. So you can see these boxes. So if bempedoic acid and ezetimibe are available, you give them first with statins, and then inclisiran, which are available, if they're available to you, they can be directly given to these patients. And if you look at the secondary prevention, somebody who's had an MI, stroke, etc., or recurrent events, or is acute coronary syndrome with stenting, you start with high dose statins, add ezetimibe or bempedoic acid or together to achieve the LDL-C goal. If you're not able to achieve it, then you move to the injectables like inclisiran or PCSK9 inhibitors. So pretty much similar to what the Indian guidelines are also saying. And this is the same, ACC expert guidelines also tell you the same concept. If you look at the phase 3 slides, the pivotal trials have been Orion 9, 10, and 11, and they have consistently shown effect in heterozygous familial hyperlipidemia, hypercholesterolemias, patients with ASCVD. So the Orion 10 was specifically in these patients, and Orion 11 also in patients with established ASCVD or at high risk patients. And these were for about 18 months. And inclisiran has, if you look at the pooled analysis of Orion 9, 10, 11, there was more than 50% reduction in LDL-C from the baseline. And this is something which is absolutely remarkable. And I see in my own clinical practice, where I use inclisiran quite a lot, that the LDL-C levels come down to almost less than 10 in majority of the patients. So it's a very powerful drug, highly effective and very safe. There is hardly any side effects of this molecule except for the local site inflammation and redness for some time. The good part about this is that it also brings down the triglycerides a little bit, increases HDL slightly, and also brings down LPA levels by approximately 40%. And this is important because lipoprotein little a is a risk amplifier, which is now a lot of emphasis is being given to LPA nowadays in the last 2 years with multiple studies on it. And especially in Indian subset, we found high levels of LPA associated with diffuse coronary artery disease, even in very young patients like 40, 35, 40 years of age who have no risk factors. So it could be one of the reasons why we're seeing heart disease early in some of these individuals who have high LPL levels. So if you look at inclisiran's effect, it brings down the total cholesterol levels from the baseline by 34%, ApoB by 45%, non-HDL cholesterol by 47%, triglyceride by 15%, LPL levels on an average by about 22%, and HDLC is increased by 7.5%. Reasonably well tolerated. Some side effects like nasopharyngitis, etc., have been noted, but they are non-significant. Long-term safety is well established up to about 7 years, and based on the Orion 8, which was an open label extension of the Orion trials 9, 10, and 11, and also 3, and about 4,000 patients. So if you look at the overall results of Orion 8, which is a pooled analysis of the various Orion trials, about 78% of these patients achieved the LDL goals. Approximately 90% patients achieved their global lipid target at any visit. And on an average, the LDLC was reduced by 50% at the end of the study. So it is a very good molecule which has been, introduced. The ongoing trials are the Orion 4 and Victorian 2P, which will shed more light on how inclisiran will fit into our day-to-day usage in future. But it is one molecule which you should be using. It's about approximately 1 lakh rupees per injection, approximately between 90,000 to 1 lakh. But remember that it is 4 times cheaper than PCSK9 inhibitors in the long run. So it has to be given subcutaneous in an OPD setting or in any clinic once in 6 months. So you start with 0 day, 0, 3, and then every 6 months, and quite safe. So with this, I will end my talk, and I hope this interaction will help you to start using this drug more efficiently in your practice. Thank you.